will now guide you through the steps involved in completing the nutrition-focused physical exam in Worksheet 4 of the PG-SGA. The physical exam is a key component in evaluating a patient's body composition, physical deficits and overall nutritional status. It's crucial for making a formal diagnosis of malnutrition or undernutrition, determining its severity if present, and identifying the appropriate interventions. A nutrition-focused physical exam should include a subjective assessment of muscle status, fat stores, and fluid status. It's important to note that findings from multiple sites are used to assign one overall subjective rating of total body deficit. Individual sites are not scored or added together. Each aspect of the exam is rated for degree, that is 0, 1+, 2+, or 3+. Ratings for individual sites are not additive and are used to clinically assess the degree of deficit of muscle and fat and presence of excess fluid. None equals 0, mild equals 1+, moderate equals 2+, and severe equals 3+. Refer to the how-to guide for descriptions and visual images for degree at each site. Following assessment of each site, determine the global rating for muscle, fat and fluid status based on the majority response. The physical examination score reflects the overall subjective rating for total body deficit based on your clinical judgment of muscle status, fat stores and fluid status. Remember that muscle deficit takes precedence over fat loss or fluid excess. For none, score 0 points, mild 1 point, moderate 2 points and severe 3 points. Remember, the maximum score for the physical exam is 3 points, so you're unlikely to be off by more than 1 point. Before you begin the physical examination, perform hand hygiene and use appropriate personal protective equipment as required. For example, gloves, mask or gown. Explain to the patient what you'll be doing and ask for permission to touch them to complete the exam. Respect patient privacy by conducting the exam in a private space and only expose areas of the body as needed. Muscle status is assessed at 7 key sites from which a global muscle status rating is given based on muscle mass, bulk and tone. Assess as many sites as is practical to have a global sense of muscle deficit. The muscle sites should be prioritised and ideally at least 4 sites should be assessed. Nutrition-related muscle deficit is more likely to be evident in the upper body, that is the face, shoulders, arms, scapula and hands, whereas muscle loss due to inactivity or bed rest is more likely to be evident in the upper leg or thigh. It's important to consider the symmetry of any observed deficits in muscle status and consider potential causal factors of any asymmetry observed. Additional insight into the impact of muscle status on a patient's function may be gained by observing the patient as they stand up, sit down, walk, or move from lying to sitting in bed. You can gain an understanding of muscle mass and tone by gently shaking their hand or touching their shoulder as you greet them. Observing the patient's temples and orbital fat pads while they're speaking can be helpful cues. Start by assessing muscle status at the temples, that is the temporalis. This is one of the easiest locations to assess muscle status. Looking at the patient from the front, check for hollowing at the temple, between the hairline and the eye socket. Hollowing is a sign of muscle deficit. You can palpate or feel the area by placing your finger on the muscle and asking the patient to open and close their mouth or clench their jaw. This allows you to feel the muscle tone. Next, assess the muscles at the clavicles, that is pectoralis and deltoids. Look for muscle cover below the clavicle and assess accordingly. The clavicle should not be prominently visible in a well-nourished person. It can sometimes be slightly visible in a well-nourished female, but shouldn't protrude. If the clavicle is more prominent, it can indicate muscle deficit. Next, assess the shoulders or deltoids. Ask the patient to stand facing you with their arms by their side. A more rounded shoulder with well-developed deltoids indicates good muscle cover. A more squared shoulder or prominent acromion process can indicate depleted muscle stores. Next, assess the interosseous muscles of the hand. Ask the patient to press their thumb and index finger firmly together. The interosseous muscles should be flat in female and slightly prominent in males. Any scooping or depression indicates muscle deficit. Next, assess the muscles around the scapula, the latissimus dorsi, trapezius and deltoids. First, assess whether ribs are easily visible on the outer sides of the upper back. Then ask the patient to extend their arms straight out in front and push against a wall or your hand. Look for cover over the top and the sides of the shoulder blade. A more prominent bone indicates more wasting. The leg muscles are best assessed sitting upright, slightly forward in the seat with feet resting flat on the ground. If the patient is in bed, lift the knee up so that the leg is bent at a right angle. Assess the thigh or quadriceps by palpating from mid-thigh towards the knee. The muscle above the knee should be well formed with no prominent or protruding bones or depressions. An obvious depression of the inner thigh indicates muscle deficit. This is more evident when there is also loss of overlying fat. Finally, assess the calf or gastrocnemius. The calf should feel well covered with muscle. Feel for both volume or muscle mass and tone, noting whether the muscle feels firm or soft. Fat stores are assessed at 3 sites and a global fat deficit rating is given. Note that the loss of fat tissue may not be obvious when completing a physical exam in patients with pre-existing obesity. Be sure to consider their usual body size and weight history when assessing fat stores. An area where fat loss is often first detected is the orbital fat pads. Look at the area under the eye and along the cheekbone. You may need to palpate the cheekbone to assess fat stores. In a well-nourished patient, the fat pad appears full. Look for dark circles or hollowing that indicate fat loss. Some patients might carry excess fluid under the eye, so be sure to ask about this. Next, assess fat stores in the area of the triceps on the back of the upper arm. Gently pinch the skin fold between your thumb and finger, ensuring you're assessing the fat layer, not the muscle itself. Your fingers should not touch. If fingers are close to touching, then this indicates depleted fat stores. Lastly, we assess fat stores over the lower ribs. Palpate along the lower rib cage, feeling for the soft tissue between the skin and bone. A well-nourished patient should have no visible ribs and a layer of fat covering the bones. If the patient is mildly to moderately depleted, you may see the ribs faintly with less fat cover on palpation. In severely depleted patients, the ribs will be clearly visible and you'll be able to feel the bones through the skin. The final part of the physical exam focuses on the assessment of fluid status, which contributes to the global fluid status rating. Look for edema in the ankle or the sacrum. Assess for ankle edema by inspecting and palpating the lower leg and ankle for fluid accumulation. Press down firmly on the skin, moving from the top of the foot up towards the ankle. If there are depressions present after you remove pressure, this is a sign of edema. Next, check for sacral edema. Press on the skin at the base of the spine and rate accordingly. Finally, we assess for ascites, which is fluid accumulation in the abdominal cavity and can be associated with liver disease and some cancers such as ovarian cancer. It can be helpful to check the patient's medical history for any conditions that might be associated with ascites. Assess for the presence and/or severity of ascites and rate accordingly. This concludes our instructions on how to complete the PG-SGA physical examination.